Probably not. We should never hold treatment for a patient, okay? So when you are taking care of a patient, don't ever think, I'll just wait till it gets to the ER. Treat them. Treat them. The reason we get called ambulance drivers is because half the people don't want to treat their patient, right? They don't want to treat their patient. The reason that most physicians don't have a lot of confidence in us is because we bring patients in to New Albany that should have gone to Tupelo because why? Did he know? Probably not. Like, I don't know this guy. I don't want to say he's an idiot. It may truly be ignorance, and ignorance meaning he just didn't know. Doesn't mean he's dumb, right? But who was it earlier that you were talking about? Your paramedic preceptor didn't know about a cerebellar stroke. Yeah. Because most of the people aren't taught that. Your guys are going to be taught that because Lisa and I both were ASLS instructors, and we taught that stuff. But for the most part, until I took ASLS, I know what the cerebellum was. I didn't know you could have a cerebellar stroke, and the only thing it was balance issue, right? Yeah. But it's learning. It's teaching you how to pick up on things. And hopefully, by the time you get out of this class and you are a paramedic, you have an idea of things that are going on with patients that you pick up on. And you're never going to be wrong for treating a patient if you can speak to why you were treating them. Right? If you just say, I don't know, I just threw something at them. I didn't really know what they needed. But if you can say, well, the reason I did was, their heart rate was this, their blood pressure was this. I knew I had to do something. For me, this was my best course of action. And if they're like, well, you're an idiot, you shouldn't have done it. And you're going to have people, you're going to do treatment that they're going to tell you stupid, that you don't know what you're talking about, right? Which is fine. Don't argue with them. Smile at them, pat them on the shoulder, and say thank you for that. And you go inside of my computer and walk out. It's not a big deal. I don't care. I literally had a disagreement with the guy that teaches the Gamard stuff. He's an engineer. I'm sure he's very smart at what he does. But one of the lists said bradycardia. And one of the people in there said, well, I was looking for sinus bradycardia. And he's like, well, bradycardia is sinus bradycardia. And I was like, what? Does it have a P wave? He's like, it doesn't have to have a P wave to be sinus. I was like, yeah, it does. Kind of does.
That's when you say thank you.
And he doubled down. And you know what I said? I was like, okay. Okay. All right. You can be wrong.
You taught me something new.
I don't care for you being wrong. Like, no, he's wrong. And after class, we got to talking. I was like, what was your background before? He's like, oh, I'm an engineer. I went to school. He's like, I worked in sales for a little bit. He's like, but I've always liked teaching people stuff, and I just thought this was kind of cool. And I've been teaching people this stuff. I'm like,
what was the class?
Might want to Google.
Yeah,
it was for Hal. It was all the Hals. I'll show you some videos. They have some very, very, very high tech ones that cry. Literal tears come out of its eyes. It's pretty freaky. One has AI that will answer you.
Oh, nice.
When you speak to it, and it uses AI to answer you back, and will squeeze your hand. Will reach up, grab your hand, and squeeze it. Will follow you with his eyes. Like, head will turn. You walk into the room and it notices you. It'll turn its head and eyes and will blink at you and 120,000.
You got a groomer.
It's 50.
Yeah, we should double down.
That was just eliminates clinicals right there.
He was very impressive.
That would eliminate most of our questions we have for y'all.
Correct. Yeah. And you can speak, you can build in, they even do the pediatric one. You can have a kid, they even recommended bringing a child in to record some sayings and crying. And so it really plays that sound through.
No kid.
Yeah, it's wild.
Do they have a girl one?
They do. They do. She has interchangeable parts. She can even be a man. You know what I mean?
That boy.
Well,
so
the next Mrs.
anyway,
Grace coming on.
Pediatrics.
Okay.
Don't panic about pediatrics. Okay. Here's what I need you to know about pediatrics. Okay. If you don't remember anything else about pediatrics, 99% of pediatric issues is respiratory. Okay? 99% is respiratory. Respiratory. So, when you think about pediatrics, when you think about kids, fix the oxygenation problem. All right? Fix the breathing problem. When it's a low heart rate, we do CPR on these kids, right? We do 60 or below on a baby. When their heart rate drops below 60, we do CPR on these kids, right? Why? We still have to achieve the same amount of blood, right? We still have to get that oxygenated blood going through. Y'all heard a loud truck or thunder?
I could tell that was an air turn.
Whatever. No, it's not. But we have to keep the blood pumping, right? Because oxygenated blood not getting to where we want to is cellular death, which is death, right? And so we know with kids, 60 is super slow, okay? These babies, because we know their normal heart rate is above 100, right? We don't have a normal heart rate less than 100 for a kid. So we start taking action less than 100. When it gets below 100, we start doing respiratory fixes. And these kids are brand new. Their pipes are new, their pumps new. Like it's not a pump issue unless it's some type of issue they knew about. They were in a high-risk pregnancy and they're going to be able to tell you. But other than that, it is going to be respiratory, okay? Fix the respiratory problem. Don't mean we don't have to do some pump issues, right? Don't mean we don't have to do chest compressions when their pump's not working as fast as it needs to be, right? But we got to get them up. And it's not a pacing issue, right? We don't pace pediatrics because, again, it is not. Why do we pace? AV node's not firing right? Right? So it's why we pace people. AV node dysfunction of some sort. They don't have an issue with their AV node, okay? So they have issues with breathing. And when respiratory is not working like it's supposed to, whether swelling, surfactant, whatever, right? Whatever it is, insert whatever respiratory issue we got going on, epiglottitis or, ARDS or, whatever it is for the kid, right? It's respiratory. We have to fix that, but it's not an AV issue. It's not an electrical firing issue. So if it's not an electrical firing issue, we're not going to pace it. We do chest compressions till we get oxygen fixed. Once oxygen gets fixed, guess what else follows behind it? Heart rate. Heart rate picks up. And if it don't, we code them, right? And statistically speaking, your data will show that CPR on these babies, once it gets below 60, starting chest compressions, if they do code, we have a higher likelihood of getting them back if chest compressions has been going on, right? Okay, what else? Let me take this real quick.
Okay. So, a couple of notes from our pre-lunch scenarios. Number one, does everybody know how to defibrillate with this machine now? Okay. It's going to be over here on your side.
Hold on a second. Can I look at it?
That's, yeah, go ahead.
So, when I did it, it was just like that. It didn't have anything on it, but it's just the bottom right with the lightning on it that I didn't see when I was doing my scenario. It just brings up that home menu.
And if you want to defibrillate, okay, what if you want to sync?
Well, it was syncing, now it's not.
That, yes.
It was syncing, now it's not.
Correct.
So did
The
I?
dots, there's dots up there. Just put that
Very
in there.
minor.
It's cheap. Yeah, it'll tell me on my monitor if you sank and or defibrillated.
Where do we go to pace? Okay,
Turn it
so
on and you set your rate and your current.
So this is a very real life scenario. You go to a new company you're working for. If you don't know how to work the equipment, you've got to find somebody that can walk you through it.
So that's how you get to your 12 lead.
Okay?
You can actually print on here, shit.
So, knowing our equipment. Number two, if we are in a...
There's a CPR thing.
if we are in a full code situation and you feel yourself getting stressed and you think you're kind of lost, as long as you have somebody doing high quality compressions and your airway's taken care of, step back a second, take a breath, think, okay, here's where I'm at. Let's try this. Kind of get it in your head. There's nothing wrong with that. It's a lot happening all at once, and you've got to be the director. Okay?
See, what I had a paramedic tell me, he said in any bad call, if you ever get disgruntled or discouraged or anything, he said step back. And he said go back to your ABC, start back off,
100%.
and you'll catch right back to where you're at every
Absolutely.
time. So
Because
if you get
you
lost,
will
start ABC back.
you will have this problem in real life. It will hit you like, what the hell am I supposed to do now? And you get frustrated, and then the more you get frustrated, then it just snowballs, right? Take a breath, think about your ABCs, okay? If it's full arrest, let's hit our H's and T's. What can we do to maybe reverse it? Blah, 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 okay? Fundamentally good assessments. ABCs. Sample. Make sure you get your allergies before you give a medication to somebody, right?
12:53 p.m.
Thank you.
Thank you, Siri. Does anybody have suggestions or questions about how we could do this differently that would benefit you better?
I'm liking this a lot better with that to him.
Okay.
Because it feels a lot better being able to actually, got a pulse,
Okay.
chest
That's
compression.
been better than the other.
Yeah.
Okay.
It just doesn't look the same. We're not used to the monitor, but I think it kind of improves our
Yep.
ability to overcome whatever we need to.
I think we should just start ramping up scenarios,
Yeah.
getting 2, 3, 4, 5 a day.
Okay.
Each group, just
Yeah.
really,
Drilling going in.
yeah, just
Okay.
repetitive if we have to.
All right.
And do somewhere. We all start outside, come in,
Okay.
and then mix,
Moving
better
on.
mix.
One thing I will say, one thing that is catching me off guard is like when we go to the ambulance, and then it's like all of a sudden, hey, you're 3 minutes out.
Yeah.
I want to like do more because like a lot of times, like at MAG, we especially as soon as we get in the ambulance, we take a second, we're doing our vitals, doing the rest of our stuff. I'd like to have the opportunity to say, okay, now we're going to transport.
Okay.
So I have time to actually now gather because like it catches me off guard when we're 3 minutes out and I'm still like in the middle of
Okay.
doing stuff.
Yeah, and then you've got to try to get your mind
Yeah.
right for
It's
the
kind of
radio
real with
report.
like with a
Okay.
bad call because you're already on your way.
Yeah,
Well,
'cause
see, then
you
that-
get
then I know I'm
a lot
on
of
my
times
way.
to look back at the monitor and be like, oh, it's O2's 89. Let me throw them on something
Yeah.
real quick versus when I'm.
Okay. Let's get Hal on the floor. Get our first pair.
Can I try the CPR function real quick? Just
Sure.
Second semester. We better do it that way. Because I got so many titles next semester.
Just whenever you get me a date, yeah.
Okay, I'll look on the schedule and send you a text on that.
Okay.
Thank you. I just wanted
I
to.
genuinely would have thrown all of my spine.
This might be a day. Rate's good. Compression needs to go more.
That's like the freaking ACLS dummy.
Yep.
John, we're gonna go.
Okay.
Okay, John, that's fine. Go be with your new friend.
Oh, I just closed it. Sorry. I just hit it down.
It's the little hands.
Yeah.
Right there.
Well, we're finna get started though.
You wanted to do it real quick? No, I already did. Sorry. Close.
Okay.
What are you? Sorry.
Dude, you seriously need some GERD medication. I'm not playing
I
with
didn't
you.
work that.
You need it.
I know.
Do you have trouble sleeping? Do you have a lot of heartburn? Okay.
Sweats? Do you have headaches constantly? I have trouble sleeping, but
No, my pupils are dilated.
have you been having some weight loss? But it's because I still see the face.
Yeah.
Whose face? My face? There's yours.
Okay. Are y'all ready?
Yes, ma'am.
Children in the corner, are y'all ready?
Yes.
Okay, medic 4, you're dispatched to a 67-year-old female, general sickness,
General sickness. Okay. Where is this patient at?
in her living room.
In her living room. Okay. When we walk in, does she notice us? Does she like appear alert?
She looks at you.
She looks at us.
I smile at her, she smile back.
No.
All right. Hey, ma'am. My name's Justin. I'm gonna be your paramedic today. This is my partner, Jonah. Can you tell us what's going on?
Don't feel good.
Okay. Can you explain a little more what you don't like? What's not feeling good?
Now that you're up close, you see that her her face is not symmetrical. One side's drooping.
Okay.
Nice.
All right. Let's get the vitals hooked up here.
Go ahead.
I'm gonna go ahead and check her blood sugar. What's that?
122.
122, okay. Alright, can we request a helicopter?
You're no, no,
Wow.
because I said so.
It's raining.
Well, that's usually the response we get, but that's part of the things to run down, calling for a helicopter.
Yeah, that's not happening today.
Okay. Alright. Let's just go ahead and grab the stretcher. Let's get her loaded and go. Does she have any family around?
Yep.
Okay. I'll get her loaded up on last family some questions. So, about what time did all this start?
Well, I saw her come downstairs about 45 minutes ago. She seemed okay.
Okay. Has she ever had a stroke or anything like that before?
Has not.
Has not? Okay. Does she have any allergies to any medications?
Does not.
Does she have any past medical history that we should know about?
Hypertension.
Hypertension? Okay. When was the last time she ate anything?
I'm not sure.
Not sure. Okay. Well, we're gonna get her loaded up and we're gonna take her on down to the hospital, okay?
Mm-hmm. But just leave it there so we can hear her better.
Gotcha. Well, I guess I ain't gonna do that.
It's back on that new one.
Okay. Alright, sweetie, can you grab both of my hands?
She does grab both. Right side weakness though.
Right side weakness. Okay. Alright, can you push me away?
Same result.
Alright, pull me towards you.
Same result.
Alright. What about on her feet?
Same.
Same. Okay, so just right sided deficit. Alright. Then we're just gonna go ahead and transport emergent to the closest stroke facility.
Okay.
Alright. Ready for report, I guess?
Mhm.
Okay. Alright, medic 4, northeast.
Go ahead, 4.
We're gonna be en route with a 67-year-old female. Chief complaint today is gonna be right-sided facial droop. Whenever we got to the scene, we could notice that she had right-sided deficits. Family stated this started approximately an hour ago. We got you a set of vitals. Heart rate's currently 89. Blood pressure is 186 over 103. Breathing about 19 times a minute. She's currently at 95% on room air. We should see in about 10 minutes. Require any further?
No further. ROA. Simple. All right.
Question. Can I ask a question?
Yes.
I know it was obviously a stroke, but did you ask her if she has cerebral palsy?
What was her blood sugar?
122.
I just,
Where's that? Was this thing?
I don't know.
Oh yeah, I forgot. I passed on the side.
There you go. Thank you. All right. Do we notice anything that we forgot?
Probably.
Did you get IBS?
He didn't do the essential oils.
Did we do allergies and blood
Yes.
sugar and all that?
He
Yes.
did. Yep.
For those of us paying attention, yes, he did.
I was good. Thank you very much.
One of the first questions he asked after wing availability.
He asked if there was somebody there.
Okay. Now, on a serious note, let's talk about it. When would you consider air transport?
You're in Itawamba County.
Okay.
You're far away from
If my scene and transport time is significantly greater than wing getting there, then I would go by ground. But if they can get there to me quicker and them to the appropriate facility faster than I can, I'd probably choose that.
Okay.
Like when I worked in Calhoun County, it'd probably be an hour and a half, hour 45 to get to Tupelo.
Okay.
So it might be a consideration. But if I'm in DeSoto County, I'm right,
Right.
there.
Yeah. Okay.
I mean, that's with Mag. That's why that popped in my head because it's like if we get on scene and we see this, you're instantly calling scene 48 will fly so you can rush them to 58 and let them take them on down to 50.
Yeah. Makes sense. But for all of these scenarios, you're probably never going to get a helicopter from
Well, I
me. So
figured, but it's just going through the
Okay.
motions.
What if he
Well,
did?
I think we want to get used to the calling for it and being denied.
yeah.
We want to get used to the rejection.
That's-
That way, when we get out there, we're like,
What if
I
he did
figured
Kirk
not.
joined the scenario?
Did that?
He just grabs Hal on the stretcher and walks off.
Next thing you know, you see Pafford landing right out here in the field and getting ready.
All right.
Well, Wes is going poop. Let me go check on him.
I think Hal's neck might be messed up again.
It is.
Not me, I was driving by the torso. I didn't do it.
I was grabbed by the neck.
Yes.
So with our clinicals, we're supposed to be putting competency for everything.
Yes.
There's,
I thought we were told to put formative.
No, wait, it's been put forward, we're supposed to be putting competency.
Competency.
so there's a bunch in here that says form. So that's my question. If we have her example, can some of the formative skills and stuff be changed to competency?
Sure.
Because she thought
Yeah.
it was just supposed
Yes.
to be formative. Or like if we have a bunch that are competency, but we have formative that we haven't fulfilled,
Your
Right.
formative,
cardiac dysrhythmia.
you should not
formative.
have competency without formative. So you should never have gone straight to competency. Competency means you're competent. Formative means we are learning the skill. So you never should go straight to competency. So if you went straight to competency, that tells me you didn't log some or you mislabeled the first few that you did. Your first few until you became competent should have been formative. That's all that means. Formative means you're learning. Okay? Competency means a competency on this stretcher would be me saying, hey, go in there and grab the stretcher, load it up, put it in the back of the truck. Right?
Right.
And so that would mean you walking in here without any instruction, raising it up, pushing it in, lifting it up, raising the legs, putting it in, latching it in place, and saying, all right, we're good. Formative would be you saying, hey, I don't know how this thing works. And it would be me coming in here and saying, hey, this. And your first few times of doing it, that would be formative. You'd log those formative. But any other time you loaded that stretcher in would be competent. You didn't need my help, okay? You didn't need somebody's help to show you how to do something. So once you get competent in it, doesn't mean you're a savant or know everything that's going on with it, right? Doesn't mean you're a subject matter expert. Just means you are competent. You are basic level understanding and can operate it without somebody being like, you got to press that red plus button to get it to go up. Cool?
You try to wipe your ass in the dark in the room. I mean, my question, this will.
I was trying to help you out.
I understand what you're saying, and I think
Literally.
the question didn't convey what I was asking quite right.
Sound.
Oh, you still have bonds coming out?
Yeah.
Medical neurological pathology.
You gotta learn how to echolocate, bro.
And this is the
I have blind people out there, though.
pathologies for our real life patients.
I guess it's like, I saw it.
Okay. Let's get over talking about poop.
These should still be formative.
So
This
until,
one-
even if we feel like
I have a pen if you
You
need
have to
one.
have 8.
I have my last one, I just don't wanna use it.
so we have to keep track of. Okay, gotcha.
Yeah.
Okay.
I framed mine.
So, but once your formatives are done, you should be in the competency.
See, like right here, I've got 32 of 12
Uh-huh.
formative.
But you're 10 of 6. And,
Right, right.
yeah, so it's fine.
Unless you
I wouldn't go in and change those.
Right.
But I would go change my competence. If my formatives are not full, I would change my competence that I list as competent to formative.
How do we change that? Is that stuff not gonna have to be sent back to us?
Problem.
We're going over our skills.
But going forward, you don't move until your numbers are checked off on formative. You can't move. That's what I'm saying. You should not have gone straight to competent unless you were
Well,
done.
At first I was checking formative, and then one day you told us to start checking competency.
Only on, yeah, but until you meet minimum standards. So you still have to have minimum standards for formative, right? Like,
We interpret it as like.
just go ahead and do everything.
Like midway through this semester, or whenever you mentioned
Yeah.
competency, we were like, okay, we can start doing that on everything.
So I think the one we were specifically discussing was because we had all those patient assessments and y'all had 0 patient assessments. And I'm like, y'all have had patient assessments. So because we had done, if you documented them, again, it's all about documentation. If you documented every one you did, you would have had more than enough formatives and probably halfway enough by then, half enough competencies to be done, right?
Well, if
So-
you're documenting on the app, it doesn't give you the option to
document an assessment, but if you go on the website, you can document an assessment.
You should be able to do an assessment on the app too.
Like
For-
it doesn't let you add it into the skills.
Yeah. Either way,
Okay.
So we need to be checking competency now.
no. Hold on.
It's just
'Cause
opposite
last time
what
I
he just
said that, we got all off whack. You should have, if you have 8 formatives that you have to have, and you're 4 of 8, you should not be listing competency. You have to have, accreditation states that you have to have 8 to be formatives before you can mark competent.
So how do we
See it
know
on your
if we have
progress
all our
report?
formatives in that?
Go in
Yes,
that
you
file that he has
you
pulled
have
up.
to go
right there.
on the actual website version that you can't get your report through the app.
But you can pull your report.
But like you were saying.
You can see how many you have. You'll see what your CMS is.
096 on copy.
CSM or whatever it is.
Oh, so you've got your formative cardiac arrest and you've got your competency cardiac
Yeah,
arrest.
that's where I got
So
confused.
before you can fill out your competency, make sure that formative is 100%.
That's and you probably had plenty of formative because of that.
Because I remember that's when we started, that conversation came up.
Correct.
And I was like the only one that had. any
Yep.
progress
Correct.
on that.
Yeah.
Because I was putting formative on like most of them, and then towards the end of it, I started putting competency.
Yeah.
That's what I've done.
So like you run
Once
through
you're-
a whole bunch. You run through a whole bunch.
And
of
you
them.
may be fine as long as you were doing your documentation on all your patients. You probably got, if you were listing them as formative, you probably have your numbers.
So what it
You
is
just have
is
to go in there.
As long as you're doing clinicals correctly, you should be fine. Theoretically.
Yeah, but make sure, go in your report, pull your report up, and look, how many formatives do I have? And if it's 8 of 8, or in his case, he had like 36 of 8 or something. That's fine. Too many, that's a minimum number. The minimum is like the minimum that you have to have before you can move on to competency. Okay?
Also, I think the
One of those
the
is
EMS
one
assessment,
of
like
those
in the
is-
skills.
so SIMR
I think that's just automatic. Because when I went into my report, that was like
I'd go on the website.
that was like it was the blue, so like it was already like automatic 100%. I think
Yeah.
it just that's an automatic if you're doing like a patient on platinum. Like you don't have to add that on there. It's just automatically
Yeah.
a part of it for doing the patient.
Okay. Ready, fellas?
Yes, ma'am.
You're dispatched to a 31-year-old female who just delivered at home.
Can we get the baby one out too?
No, it's fine. Because the second crew or the first crew took the baby, so you're just getting mom.
Oh, so we're just picking up mommy.
Yeah.
Okay. Is there any like helpers on scene?
Sure.
Cool. She just delivered a baby.
You walk in, there's an EMR trying to pack her vagina.
Hey, stop that.
Good job, buddy. That's what we're trained to do.
Hey, why do I have, like, why do I have to like?
All right, so- We walk on scene, open the door. There's an EMR tending to the mom. If he's actually packing the.
No,
Okay.
but he's there.
Is there anybody else on scene, family wise?
No, because baby daddy went with the baby.
How's mom look? Is she pale, diaphoretic?
She's extremely pale.
Okay, my partner's gonna place her on the monitor. Hey man, can you talk to me?
Yes,
Heard you just had a baby. What did we go ahead and name him? Is it a boy or girl?
it was a boy,
A baby boy. What do we name him?
Enrique.
Enrique. Okay, well, we're gonna get you on our stretcher and we're gonna get you to the hospital. Okay?
Okay,
Do you want to go to the hospital?
I think I need to.
I think you do too.
I got a lot of bleeding.
There's a lot of bleeding in the distal region of her abdomen.
Mm-hmm.
All right, we're gonna get her on a stretcher and then we'll take her from there. All right. Jeez, she's heavy.
You need to lose weight.
My God, man. I apologize for that, man. He was just joking.
We actually loaded.
So,
Alright.
alright, ma'am, I'm gonna ask you a bunch of questions. They might feel kind of silly and repetitive. Are you allergic to anything?
No,
Now, I would not have to ask this. I could just look. But visually, is there?
a massive amount of blood.
Okay. So, what I'm gonna have my partner do is start not packing, but just like placing ABD pads
Okay.
in between there.
Mm-hmm.
And we're gonna start an IV on her.
Okay.
You take any medications?
Prenatal.
Prenatal? Okay. So, in my mind, I'm treating this like a hemorrhage, like we got a bad hemorrhage. So,
Mm-hmm.
I would start an IV,
Okay.
hang some fluids, KVO,
Mm-hmm.
try to think of bleeding control measures and just get to the hospital ASAP.
Okay.
And then just reassess. Continuously reassess.
Mm-hmm. Are you done with your assessment and everything?
No, that's just the
Okay.
where my mind is at.
I got you.
So, is her level of consciousness, is she still kind of like with it?
Yeah.
Are her eyes normal? I'm good to head to toe.
Pearl?
Anything weird with the eyes? Ma'am, are you hurting anywhere besides where you just delivered a baby from?
No.
No? Okay. Get a blood sugar?
132.
132? Transport.
Okay.
I don't like the looks.
I mean,
That's what I would do. That's
Okay.
where my brain is at. That's the best I got for you.
okay. Do you want to give radio report?
Yeah, sure.
Okay.
Bring.
Go ahead.
Bring. Hey, this is Unit 4 bringing you a... Oh my god, I'm so sorry. Let me... Have you had any pregnancies in the past?
Yes.
How many?
4.
How many children do you have currently alive?
Now 4.
Now 4. Okay. Now I want to call a patron.
Okay.
Any complications with those deliveries?
No.
None? Okay, has this ever happened to you before?
No.
Do you have any prenatal issues?
Not that I'm aware of.
None that you're aware of? Okay.
Hello.
Hey, this is Wes on Unit 4. I'm calling patient report.
Go ahead.
I'm bringing you a 31-year-old female post-delivery. The baby has gone with another unit. She has had 4 pregnancies, 4 deliveries, 4 live children. Her heart rate is 148. Her blood pressure is 182 over 45. SpO2 is 99. Blood sugar was 125.
What was that blood pressure?
Did I say 183? I apologize. I'm so sorry. Correction on the blood pressure. It's going to be 82 over 44.
Okay.
We've got a bag of lactated ringers hanging, KVO. We've kind of put some pads where she's bleeding quite a bit. We've kind of padded it underneath. Do you need anything else?
No further. ROA. Okay. Thank you for going back and get your Gravida and Para. That's important. Did we have any thoughts of maybe a fundal massage?
I was thinking that.
You just didn't say it? You just let your partner?
Kind of letting me go.
I'm not going to lie. Didn't even come to my brain.
Yeah. What?
Did you do TXA?
I probably wouldn't. I'd probably go oxytocin if you had it. Another thing, when you're going to put a lady who just gave birth or anybody that's bleeding excessively, if you have time and you have it, put one of those chuck pads down.
Mm-hmm.
It's going to, number one, protect the stretcher. Number two, it's going to be a good visual of, okay, this is how long she's been on the stretcher. This is how much we've lost.
Where are the chuck pads?
Like the puppy pads?
Yeah, you know, it's like a,
I just never heard
I don't know.
chuck pad. I just hear pad.
yeah, same thing.
Well,
I'm old. It's a chuck to me. But that's all you could do. You know, the fundal massage, if you...
What? Dude, I hate to ask, but I don't even know. You just... I'm not trying to be smart at it. Like, I legitimately don't
it works
know.
better if you whisper in her ear while you do it.
No, no.
Since your baby mama, since your baby daddy's gone.
Is he in the picture? What's the deal?
All right. So where is the fondus? Correct.
Neither of you knew?
I'm not bringing you up short.
No, I get it.
Is it kind of, you know how people like they rub their stomach?
You're not gonna rub the belly.
No, I'm saying like that's what people do
It's
when
a-
their stomach hurts
it's a-
sometimes.
it's
but
a-
it's lower, right?
It's a
Like
fondal
on the
massage. in the fundus area, which is above the bony portion, right? There's a soft spot above the bony portion.
Yeah.
Like where the bladder's at, kind of, sort of?
Similar,
On
yeah.
Kinda.
I mean, the bladders are here, but you're directly above the pubic region there.
So I guess
And
right
you
below
just
the belt line.
press on it? Like, I'm just
It's a
putting
massage.
pressure?
You're not just pushing.
You're gonna be moving it.
You're just, it's a gentle massage. It's not.
Not
you
very
shouldn't-
hard.
You're not trying to release myofascial.
No patient,
Tissue.
no patient elbow.
Yeah, it's just a constant massage. There was something you said that I was. All right, so couple things. And we've not covered this, so this is a shot, but just for future reference when you're talking through it, when you're discussing patients been pregnant, how many deliveries they've had, that's para and gravida,
Yes.
right? And so when you are giving that radio report, you would say P4, G4. Yeah, so it's P4, G4. And para is deliveries. It's backwards, okay? So in your mind, when it says P4, G4, if she's been pregnant 6 times, but only had, I think you have to fact check me on this, but I believe it's anything 20 weeks or above, which is considered a viable delivery. Is anything 20 weeks and above would be considered a 1 para, right? And so para 3 G6, so P3 G6 means she's been pregnant 6 times and delivered 3 viable babies. Anything delivered before that does not count, okay? So it's a better question to ask. Sometimes, especially if a mom's lost some babies, it's better to, when you have that conversation, you're asking like, hey, is this your first pregnancy or how many times have you been pregnant? She may say, no, I have 4 kids. Have you had any other pregnancy that made it to 20 weeks or after that you delivered? And so that way that gives you kind of cool. Versus, hey, how many of your babies are alive or however you worded it. Sometimes that can come off a little harsh.
Dude, no words. I just did not.
Yeah, no, you're good.
Would the delivery of the placenta be thought of at all in a situation like this?
So,
or would that be something you worry about?
Yeah, I'm not worried about delivering the placenta. The placenta will be delivered. Remember, we clamp cut between, right? But the placenta may deliver, it may not deliver. I'm not worried about it. We're gonna do a spinal massage.
If it doesn't deliver before you get to the hospital, oh well.
Oh well, correct. Yeah, because here's the thing: we've clamped it off. It's already removed itself, and so it's going to come out eventually. Whether or not we're not going to pull it out, it comes out. It comes out. If it doesn't, we now have 2 patients. Last thing I'm worried about is that placenta.
So that last crew, I wonder what their mindset was.
They wouldn't have
just take the baby.
They wouldn't
leave
have.
this lady.
You wouldn't have.
In real life, that wouldn't have happened.
No,
She did that to take their mind off of, hey, I have 2 patients, but you would not. You would be there because crew shows up. The only time that happens, mom is in a car accident and has to be extricated and the baby delivers. Then there's some way you got the baby out. Then you may take the baby while mom, it'd probably be one of those more of baby delivered at home in a situation they were driving to the hospital. Had that actually happen to me, not from a delivery, but child got hit in the head, had a huge hematoma on the face and head. Mom and grandmother started to the hospital, got to Tupelo, ran a red light, got T-boned, rolled their vehicle off. They had to be extricated. They handed me the baby through the window. I took baby, ended up in Bridget Wilson's office actually because I didn't have an ambulance. And so I was in my response vehicle and I had one of the firemen to drive me in. I was a mile down the road from the hospital, but somebody complained that I came in with a patient in the back seat of my truck. And I'm like, that's what I said.
Yeah.
Yeah, I'm like, well, you can fire me, but I would do it again. No, they were fine. She was cool. She was like, that's all I needed to know. I got in the back seat. But they were like, he came in, didn't have the parents because mom and freaking grandmother had to be extricated. Like it was a whole situation. and it was like, at that time, there was an ambulance, and I was like, I could have waited 30 minutes or however how long. I didn't ask. I was like, I looked at one of the Tupelo firemen. I was like, hey, you're coming with me. You're driving. All right, get in my truck. And so we didn't run lights and sirens. We just kind of eased down the road. But and he was fine. But it was more so, my concern was he had a head injury. He got into an accident where he was under strain sitting in the front seat with mom, right? Got T-boned. They rolled off down an embankment. And I'm like, no. Unrestrained, rollover, already a head injury. Who knows? So, anyway.
We've had to separate before from my home delivery. She had the baby and she was ODing and she had the baby, didn't even know it, left it on the floor. So they clipped it and coded the baby to the hospital, and we had to respond later to pick up mama.
Oh, yeah. Yeah, that'd probably be the situation. But ideally, not going to be. It's just going to be you and two patients.
Just trying to be good to you.
Yeah.
All right, y'all ready?
Any questions on that call, what you saw? There's something else I saw that I meant, and it slipped my mind. Hopefully it'll come and I'll talk through it. But
So you could have done the massage or
Pitocin?
Oxytocin.
Yeah, oxytocin, Pitocin. Remember, that is the medicine that we give for A, to start pregnancy, right? Or B, to stop the bleeding. Like it will stop bleeding on mom.
Isn't Pitocin the artificial form of like the naturally occurring oxytocin?
Correct.
Where is mom bleeding in this?
It was a vaginal bleed.
Yeah.
No, I understand, but like
Internally.
just somewhere on the inside, something ruptured, or it's
Could
just
be.
not-
You just never know. I mean, when you put your fingers up there, you should have palpated the elbow deep. When you do that, you got to put the glove on that goes all the way up to your shoulder.
The calf birthing glove.
So you would.
if the massage doesn't work and you don't have Pitocin, could you
You don't
give
pack it, but
TXA?
you apply pressure.
I'm not giving TXA to a mom that's bleeding. I'm starting a large bore IV and going to give fluids. I'm not giving TXA. My TXA is very limited to a
Bad trauma.
I think I'd ask like if she remembers delivering from the placenta, like, hey, was it all there? If you can remember, like, did you notice like part of it?
Right.
Because that could have been some like why she was bleeding. Is part of it's left in there.
Yeah. Maybe.
All right, Medic 4, you're dispatched to a 35-year-old, shortness of breath.
Alright, we get on the scene. Where are we at? A house? A business?
You're at a house.
A house. I'm assuming the scene is safe.
Scene is safe. He is sitting on the porch.
Okay. So how does the patient appear to me? Like, does he have increased work with breathing?
He does. He's extremely sweaty.
Okay. Okay. Does he make eye contact when I come up?
He does.
Okay. I'm gonna introduce myself. Hello, sir. My name's Ingrid. With our ambulance company. Can you tell me what's going on? Yeah, would you get some oxygen out for me?
I'm having trouble breathing.
I'm gonna breathe on 15 liters. We're gonna inflate the bag first.
It's inflated. It's fine.
Yeah.
I got him hooked up to the monitor.
Okay. What's going on today? When did you start going for a breath?
I was outside, working on a fence.
Okay.
Something bit me or
Alright.
stung me or something. I don't
Do you
know.
have any known allergies?
No.
Okay. Has any of this ever happened to you? Do you have issues like bee stings or ant stings or anything?
I haven't before.
Okay. So when I initially look at him, do I see any like rashes, hives? Do I see any like places he was stung that's obvious?
You do. He does have a rash. He's no shirt on.
Okay.
So you do see a rash, and then when you check his back, he's got a obvious sting spot in the back.
Haley, if you would, we've already got her bag. Would you start an IV on him real quick? I'm gonna give him some IM Epi. It's the 1 in 1,000. I'm gonna give him, depending on protocol, probably 0.3, 0.4. I should know that. You better.
I hate the scowl.
So we're gonna go ahead and give IM Epi. Before that, I'm gonna ask.
What dose did you say you were going to give?
Well, it depends on protocol.
Make a decision.
I'll give 0.3.
Okay.
Of the 1 in 1,000 Epi. I'm gonna give that IM in his shoulder while she's getting the IV. Was she able to get IV?
Mm-hmm.
Hopefully, we want to do a large bore just in case. Okay, so we've got that in. Got him on there. Okay, let's go ahead and give him the ambulance and then start some fluids. Yeah, we can also get some Benadryl. Yeah. Alright, let's get, you wanna load him and stuff?
Not into the truck, but onto the stretcher, yeah.
Do I notice any change after doing that epi?
He seems to have a little bit easier time breathing.
Okay. I'm gonna check lung sounds when we actually get him in the truck.
You have audible wheezing
Okay.
bilaterally.
Let's go give him Benadryl. Let's give him.
What's your dose?
Let's give him 25 to start.
What's your delivery route?
Delivery route. Can it be IV Benadryl? Shut up. I don't.
Okay, I'll let you think about that a minute.
Then I'm gonna go ahead and just do a Duomed
Okay,
breathing treatment. Albuterol and hypertrophin.
okay. Dose?
Sorry, just all.
Okay. Does your-
It's like 2.5 and 3 milliliters.
Correct.
It all just
And
went
it's
in my
like
head.
0.5.
What is it?
The Doneb.
Okay.
Is it 0.5 or whatever, however you said it? And the 3.
Okay.
Let's go ahead and brief his vitals real quick. I'm gonna ask him, so do you have any medical history? Any heart problems, lung problems, anything like that?
Nope. Healthy as a horse.
Okay, and go ahead and check his sugar as well.
120.
Okay. We've got a liter, what was it, the OR going in.
Okay.
Is this still his oxygen saturation?
Yes.
190, okay.
You came up a little bit.
Alright. Let's see, so his heart rate's gonna be elevated because of the steroids. I don't know if there's anything else I want to do. Give fluids. Okay, so we got.
Did you get Cyanotrol in this situation?
I would. Sure would. If you're treating me, I hope you do.
Yeah. Let's go ahead and do that.
How much?
125.
You knew the dosage for sodium Medrol and didn't know the dosage for Benadryl?
Yeah.
Bold move, Cotton.
I need to.
Okay.
Alright, let's go ahead and transport to our nearest facility. Keep that fluid going in, then reassess vitals in a little bit.
Okay.
How's his rash look? Like, is there anything
It's not really changed.
not really changed? I'm gonna ask him, do you feel like you can breathe a little better now?
Yes.
Okay. Alright. Okay. Transporting, how many minutes we got?
About 3.
Okay. Alright, go ahead and call into the ER. This is Ingrid on Medic 4. We're coming to you with a 35-year-old male. Chief complaint is going to be allergic reaction to a sting. Vitals are currently 137, heart rate. Blood pressure is 81 over 51. O2 is 93% on 15 liters after a Duomed breathing treatment. we've given 0.3 epi of IM with Benadryl, 25, and then we've given, I'm sorry, my words are 25 solely Benadryl, ain't required anything further, and all the sugars 125.
Nothing further, ROA. Okay. What are we thinking?
You know what I'm thinking?
I need to go. I just need to. Like, I know the dosage.
Tuesday is gonna be a medication test.
Hell yeah.
Be ready.
So does that mean we're not taking the other one?
The other one's Thursday.
We're not. Scratch that.
Third one is
Yeah.
Thursday.
The test from the chapters that Lisa covered is Thursday, that we went over today. Today's Tuesday. A week from today, you have a medication test. You need to know trade name, generic name, dosage, indications, contraindications,
Route.
dosage. Adult, I'm not going to challenge you on pediatric dosages right now. But you need to know adult dosages.
Question, can you send us out like a list of all the medications?
You got a book with all your medications in it.
So you want us to know, like?
Yep.
Okay.
All
So
64.
the 1 to 1,000 epi dose, is it 0.3 to 0.5?
You're right.
Correct.
Just one.
Yeah, you were.
Because I've looked at several different courses. It says
If there is nothing else that you learn in this class, I hope you learn to treat anaphylaxis. It is my pet peeve because I will die. When you see it, you did right by doing the epi first, right? If you got a partner, let's get them on that Duaneb ASAP, because that's going to help calm them down, because they feel like they can't breathe because they're getting closed off and they can't, right?
Yeah, we're still having too much hesitancy in our decision making, but medications are something you got to know. Like, you got to know medications. That's why I was a little. I mean, to know the dosage of Solu-Medrol and not know the dosage of Benadryl. Benadryl's
now I can remember all
12
my
and a half
doses
to
'cause you're not
25,
looking at
right?
me, but-
And so knowing the dosage for major things that you're going to use, like I'm probably not going to test you on a random drug that you've never heard of or something in that book that we don't use, right? Like etomidate. I may, but I throw that out because how often are you guys going to use etomidate?
Well, that's what I was meaning.
Yeah.
Like
Well, you need to know it. You need to know it because remember, National Registry doesn't test you on state guidelines. They test you on national guidelines. So if National Registry says you can RSI somebody, you need to know how to RSI somebody for National Registry. I've never had a question about RSI anybody on National Registry, but I'm not going to test you on knowing the dosages of some of those RSI drugs. However, you need to know both EPIs. You need to know Cardizem. You need to know Verapamil. You need to know Zofran and Phenagrin and all your major drugs that you're giving. You should know the dosages of all those. You should know the indications of all of them, contraindications, right? You should know this stage in class. Do what?
Like I focused on the medications that were
Yeah.
on the truck, but I also studied the other.
Yeah, and that's fine because ultimately you're going to need to know those medications that's on your truck. That's where you're working. That's where your protocols are. But having a set protocol list, in which again, my goal by this fall is to have a protocol list for here, so that y'all have a list of protocols to use in here. So it's not like per protocol, and that's why I said make a decision. All right, make a decision. 0.3 to 0.5 is the dosage, right? And so 0.3 would have been right, 0.4 would have been right, but here's the thing. If you're wrong, I'm going to tell you, nope, that was wrong. Hey, the dosage is this, and we'll move on. Like, I'm not going to beat you with a stick because you said the wrong answer. But what gets me more than anything is our uncertainty. We're like, make a decision. Even if it's the wrong decision, fail fast, move on.
Bad
right?
decisions, but of no
That's
decision.
right. Make a decision. It's like, I'm gonna go this. Don't ever in a patient situation with a patient there say, I don't what's the dosage? You know what? If you don't know it, look it up in the real world, right? If you are like, crap, I can't. Sometimes it happens. Sometimes we have brain farts. There's a woman that I talk to weekly, and I went to send her an email a little bit ago, and I was like, good Lord, what is her name? See her face, couldn't get a first name or a last name. I'm like, oh geez. I thought I was going to have to call somebody and be like, hey.
Like, how about I just avoid, like, that's what I'm worried about, like, tomorrow. Why don't you do the same thing, just like.
So for that is knowing your information before you get in there, right? We may forget names, but when I go in, it's not going to be a hey, what blade do you want? And I'm like,
purple.
What's my options? Right? You should know before you go in. It's a Mac, it's a Miller. If they offer you DL or VL, do whatever you want to, honestly. But again, my first few would be for sure. If they gave me the option of VL, I'd be like, yeah, let me do that, right? Because it is. Let me get my feet wet. Like, let me get in and get a couple knocked out. And two, I'm surprised they gave you the option just for the sake of, if it were me and I had video, at least I can be like, hey, I can see what you're doing. I'm not having to look over your shoulder as much. I can look at your video and be like, hey, yeah, that's where it needs to be.
Well, that was brilliant. She told me, she said, because she wanted me to have a good foundation of starting with DL, because sometimes your batteries and all that, she said, we're going to fail, so she'd rather start with that.
No, hey, I'm not anti. I'm just saying, if it were me, I would have been like, hey, when I feel comfortable with you, my name's on this with yours, and I don't know you, dude. So you about to use this screen right here where I can say, okay, yeah, that's good. And if anything says, like, no, I'll watch you go in, versus it's hard for me to look over your shoulder with you moving your head around when we're looking into a window that's this big, right? But again, know your meds. Y'all should have note cards. Y'all should have all your cards. I told you to make them. If you didn't make them, guess what you get to do this week? You get to make your note cards and start studying. Because we should know these drugs. We should know rhythms. We should know drugs. There should not be a rhythm that pops up on here that we question. We should look at something. It may take me a minute to be like, is that type 2 or third degree block? Right? Second degree type 2 or third degree block. Those two can take me a minute to say, all right, it's third degree, right? But other than that, I should look and it's like, shit, that's VTAC. I have a pulse, it's pulseless VTAC. I have a pulse with that, that's VTAC with a pulse, right? How am I going to treat it, right? I should be able to work through those pretty quickly. There should not be many really, and I'm not talking about atrial field with RVR, right? I'm not talking about diagnosing and saying, oh, that's atrial field with RVR or SVT, like trying to pick. I'm saying I should look and say, that's super fast, has a P wave or doesn't have a P wave, or I can't tell if it has a P wave, right? But it's over 150, it's SVT, right? Slamidinison doesn't do anything, either Cardiazem or Verapamil, ride the lightning, however you want to get there, right? But we should be able to look at a rhythm and say, this is my treatment, this is how I'm going to treat it, right? Or during VTAC, witnessed, I'm shocking. It's the first thing I'm doing, shocking it, right? Not witnessed, I'm going to do a round of CPR, then I'm going to shock it. I'm going to push a round of epi, right? Like, we should know how to run through a code. We should know how to look at a rhythm and say, this is what I got to do. Or, oh crap, what's my patient? My patient's up talking to me and I see VTAC on the monitor. I'm like, hold on a minute. Like, do we have a good reading? I'm going to check a pulse. I'm going to assess my patient, right? I'm not just going to assume. But if I see VTAC on the monitor and my patient's staring into the wild blue yonder, then I'm like, oh crap. Oh, second thing. And I know it's different. because he's laying flat in the floor, and and I don't remember how you said the patient was. I don't even know if you asked what's the patient like position when they came in.
He was sitting on the porch.
Sitting on the porch.
Okay. And I think and I missed that part, but he was laying flat. You know, when a patient's having trouble breathing, we don't ever want them to lay in. We want them to sit them up as high as we can. You know, even laid back, don't believe it, lay down and try to breathe versus standing up trying to breathe. It's much easier, right? And so getting them in position. So learn your drugs.
All right, reset. Who's the next victim?
Gabe just left. He said I can't do it.
You gotta push quick.
So was that the right medications?
Yes.
But what order would you go in?
Epi. For me, I'm going Epi, albuterol treatment, Benadryl. You can give Solumedrol, that's good. If you don't have Solumedrol, maybe Decadron, depending on what you're carrying.
It's a steroid.
Yeah, as long as it's some kind of steroid.
But you're really not Epi always first.
Just want to make sure.
Oxygen
What y'all were talking
and
about.
Epi. Like if
Right.
we're really truly
So
getting
we'll
into
start from
medicines,
the top.
oxygen's technically medicine.
Says I'm at
But
61%.
oxygen's always gonna be your first,
And then, like,
but IM
so
Epi's
you're
gonna
talking
be
about the formidable stuff.
right along in line, right? And then you're not really I guess you could say albuterol next, just because we're trying to open up best we can. But then after that, it's kind of at your own will, give whatever, but you're giving it individually. You're not mixing it all together and giving it.
See
I don't
here
mix
in the
anything. No.
parentheses.
I give it all. I give everything individually. I've never been one to mix. A
So
lot of old
So
school
they're at
medics would mix
42
stuff.
of 30, so now
Just never been my.
if
never
I
been
have
my
it,
thing.
if I guess if I have it locked out, then I can start on my formative stuff.
Miss
Right,
what?
so the adult, you got 32
Yeah.
of 30. So
Yeah,
that's fine
that's
to go to
fine if
competency.
you're
Now
gonna
you
give
got
the whole
42 of 30.
thing. But
You're
here's the
good there.
thing. Like I give Zofran first. I want it to start working first.
You got plenty here.
So, like, I'm on my antiemetic to start working because pain meds can make people throw up.
So I'm good for the most part.
Yeah.
So just, I guess on some of the skills then, like the.
For Thursday, I will try and get everybody's skills printed off to give you to make sure that what I'm seeing is what you're seeing as far as what's competency, what's formative, and make sure your numbers are right.
Just see, like, I've got cardiac arrest, pharmacy. I've also got 2 here, so I could probably add one of those there.
So is
Yes.
it gonna be how you talked about,
So
where
honestly,
you're gonna give us
You
either
want
the
to send me that
trade
one
name
back
or
yesterday?
the
I can
generic,
just send that one over as a
or it's gonna be both?
I will try to
dosage?
remember to do that here shortly.
Yeah.
Because that's what I've been marking, everything competency. That's what we were told.
Yeah,
So,
I know. I get it. We're learning
It's gonna be
together.
hard. You have to learn it. You have to know it. It's not going to be something that you can just say, "Oh, I can just learn the trade name and the dosage and fake my way through the rest of it." Because it may have all of it. It may only have one thing, and you got to fill in everything. All right, but the goal here is that you know these medicines. Okay, because that rhythm identification, medication. I mean, those are very important things for being a paramedic. Like,
You've got to know VFib, VTAC. Got to. Immediately when you see it, you need to, oh shit, we're
Yep.
pressing a.
yeah, there should not be any
No
question
hesitation.
about VFib, VTAC, pulseless.
Who you going with, Mr. Gabe?
Whoever.
You are dispatched to the Walmarts for a 60-year-old male having chest pain.
Nice. What's the scene look like when we pull up?
Hectic.
Hectic. Okay, so shoppers, bystanders, running everywhere. Is there law enforcement on scene?
Yep.
Okie dokie. Now, am I able to get to the patient?
Yes.
With ease and
Sure.
like when I get up to the patient?
Yeah, you gotta move the fire guys out of the way, but yeah.
Okay. Okay. Hey, I'm Gabe. This is Ryan. We're both paramedic students. Can you tell us what's happening today?
I feel like an elephant sitting on my chest.
Okay. So, Ryan's going to be
Mm-hmm.
doing vital signs.
Okay.
Okay. Can you go ahead and get an IV for me, Ryan? Try to give him an 18 gauge left AC. Am I good with?
Yes.
Yes. What's your name, sir?
Jerry?
Jerry, can you tell me if you have any allergies to medicine?
No, not that I know of.
Okay. Have you ever, yeah, go ahead and put pads on for me. Have you ever had atropine?
I don't know what that is.
Okay. Well, we're going to give you some atropine to try to speed your heart up. Yeah, but if you have no allergies, we're going to go ahead and do that. So we're going to give 1 milligram of atropine.
Okay.
And let's see. Can you put them on a nasal cannula, 2 liters for me, please?
Yes, sir.
Is there no effect? Okay. Okay, I'm gonna, in 5 minutes, or, yeah, 5 minutes, the time frame between, I'm gonna push another milligram of atropine. Any effect? Okay. I got the pads on them, so I'm gonna go ahead. Jerry, it looks like I'm gonna have to.
I'm sorry, do you want to wait to get him on stretcher first? You want to do
Oh yeah. Let's go ahead and get him on the stretcher before I start pacing him.
this empty vial?
So, can you tell me about your medical history, Jerry? You know, you diabetic, you have high blood pressure, anything like that?
Checkbook.
Oh,
I think there's 2.
Am I saying the right name?
I'm sorry, what? I'm sorry.
Am I saying the right name?
sure.
Sure.
Yeah, okay. Did he have any medical history?
Yes.
Uh,
He's got a history. This is the first time I've heard you say it, right? You didn't ask before that, right?
I asked allergies. He said no allergies.
Right.
And I just asked medical history. I was saying, do you have high blood pressure, diabetes?
I'm sorry, I didn't hear you say that. So yes, he has hypertension, diabetes. He had a previous MI 2 years ago.
Oh. Okay, what did they have to do for that heart attack, Mr. Jerry?
I don't know. They said something about balloon or something. I don't know.
Okay. So we got him loaded up in the stretcher. He's already got the pads on him. And I'm gonna give. I'm gonna give 2.5 of Versed to when I start pacing him, just to keep him comfortable. And the his SAT is coming down. Now, does the 2.5 milligrams of Versed, does that knock him down and affect the respiratory drive?
Are you asking if it did, or are you asking if it's normal to do that?
I'm asking if it did.
It probably slowed it a little bit, yeah.
A little bit. Okay, let's bump that nasal cannula up to 6. Jerry, we're about to start pacing your heart. It's gonna be uncomfortable, but it's what we need to do to get you feeling better.
Do you want to run 12? It's up to you. I want to make sure I can get the cord back.
I'd rather go ahead and start pacing. Okay, pace on.
Did it ask you?
Yeah.
They said it would.
It does that when they defibrillate.
How does
Yeah, because if you don't want it to, you can.
Mm-hmm.
This is nice.
Mm-hmm.
And that's his current blood pressure,
Yes.
with it being paced? Okay, Mr. Jerry, I'm gonna give you some fluid to try to get your blood pressure up a little bit. We've got your heart beating how it's supposed to. So I do a fluid bolus
Okay.
of LR. And so we're gonna transport emergently.
Okay.
And fluid bolus got his pressure up. Heart rate's still doing what it's supposed to do. How are you feeling now, Mr. Jerry?
My chest still hurts.
Your chest still hurts? Okay, I'm gonna give you 324 milligrams of aspirin. Can you chew those up for me? Okay, we got oxygen. I bumped it up to 6, right? We bumped it up to 6.
We're at 6.
6 liters.
Just looking at it.
Okay. I don't feel comfortable giving nitro because his blood pressure was already low to begin with. And he's got a history of hypertension. But we're pacing him. How's that chest pain, Mr. Jerry?
Still hurts.
Still hurts. Do we have morphine on the truck?
Mhm.
Okay. I'm going to give mm, 1 milligram of morphine.
Okay.
How close are we to the hospital?
About 5 minutes.
Mr. Jerry, how old are you?
62.
Medic 4 to North Miss.
Go ahead, Medic 4.
We got a 62-year-old male complaining of chest pain. He's got a history of a prior MI 2 years ago. We are currently pacing him. He's received Versed and morphine for chest pain, fluid bolus. Vitals are as follows: 70 heart rate pace, 100/65 blood pressure is 95% on 6 liters nasal cannula. Require anything further?
No further ROA.
The
Okay.
report just was like,
Okay.
Did I miss anything? I was a little
Okay.
distracted. Did I miss anything?
Okay. First off, let's think about our assessment. Did we ask about his skin?
I thought I did.
Because I would have told you pale, cool, diaphoretic. Did you ask him if he took any medicine before you got there?
No, I did not.
Because I was going to tell you he took 2 of his nitros. That's why his blood pressure was low. Been good to know.
Right.
It's fine to give the atropine. How do we determine if somebody is stable versus unstable? Okay, what did he have symptoms of being? What his blood pressure was?
And his blood pressure was low. If I would have, I thought I asked about the skin condition, but I must not have. But if he was diaphoretic,
Did anybody hear it? I could have missed it. Okay.
diaphoretic, cool, clammy, hypotensive, chest pain. I don't think I asked the respiratory rate.
Okay.
but you can count respiratory rate.
Yeah.
Can we see the 12 lead without it being paced?
But you have done a 12 lead before you posted.
Was that wrong? Being more concerned about.
Was he having a STEMI and that was causing his heart rate to be so low?
Okay, I took pacing off
Yep.
So why did we pace?
because I tried 2 doses of atropine and his heart rate was still bradycardic.
How bradycardic?
It was
48.
48.
So,
I should have asked if that was normal for him, if that heart rate was normal.
I mean, it's obviously not normal, right? Pale, clammy, diaphoretic. We're having some type of cardiac issue here.
Low
right?
blood
And
pressure.
I would have missed calling in instead.
Um,
I got tunnel vision on the.
yeah. Did his pain get better?
No, it didn't.
You sure?
Did you reassess it?
You did?
He did.
Yeah, he asked several times continuously if he's still hurting, if it's
Uh-uh. Are you still hurting? He did ask, are
I
you
didn't
still
ask
hurting?
If it improved,
But-
yeah.
Correct. What would you gauge it off of to begin with?
On a scale of 1 to 10.
On a scale
getting
of
worse.
pain scale.
Yeah. Did you ask that initially?
No, I did not.
No. Nor in our reassessment, right? Our initial OPQRC onset provokes quality, radiation, severity, time. S is on a scale of 1 to 10, 10 being the worst pain you ever felt, 1 being 0 pain at all, no pain at all, right? We never give a 0 as an answer. It's 1 to 10 or 1 to 5. Never give 0, okay? So 1 is no pain at all, 10 is the worst pain you have ever felt, okay? Or 5, whatever number you want to use there. Patient answers is like, I rate it as an 8. That's my initial. When I start doing things, when I go back and reassess, hey, Mr. Jerry, how's that pain feeling right now? I'm still feeling it. On a scale of 1 to 10, use the same number that you used to begin with. Don't swap it middle ways, okay? Don't start out at 10 and go to 5, okay? Second time through, hey, Mr. Jerry, now that we've done a few things for you, I gave you a little medicine for it on a scale of 1 to 10 now, 10 being the worst pain you've ever felt, 1 being no pain at all, how would you rate your pain right now? When he gives you an answer, that's your secondary pain scale that you document, right? You may even do some more stuff, you may do it a third time. But every time we do something, we don't do it immediately. If I push in pain medicine, I'm not going to ask them as soon as I give it. I'm going to give it a little bit, time to work. But when I go back through my reassessment, I have to ask on a scale of 1 to 10. That's where severity comes in, all right? It's where that S comes in our questions. And so while we follow the mnemonic of OPQRST so we don't miss something in our assessment, in our primary we're going through, right?
Was that totally off the wall given the first set before pacing him?
Not before pacing him. Did he need pacing? Probably not. He's having a heart attack. I mean, yeah.
Was he in compensated cardiogenic shock?
To guide compensated cardiogenic shock, I mean, I'm not saying he wasn't, but I need some more metrics to guide whether or not we were compensated or uncompensated, or if he's in cardiogenic shock. I mean, more like he's having a heart attack, he's got the blockage. There's probably cardiogenic possibility of cardiogenic shock coming if it hasn't already, but yeah. Questions, concerns? Remember, hey, again, I know it's summertime and I know we're real relaxed right now, but our patient assessments can be. I was hoping Lisa was being a little dramatic when she told me that our assessments were looking kind of rough while I was gone. I'm like, she's just being hard on them. But she's right. Okay? I've yet to see one today that I've been impressed with that I feel like we haven't all taken some steps back from where we were. Okay? I don't know where we got to reach in and find that other gear to find it, but not acceptable. All right?
Start with the simplest things. ABCs. Sample. That'll lead you, because if you had done sample, what would you have learned?
Well, he had no allergies. He said he had a heart attack 2 years ago.
Right.
I didn't ask what medications he was taking and if he took them today. On the medical history, all I recall is him saying that he had a heart attack 2 years ago.
Right.
I didn't ask about last oral intake or events leading to.
Especially if you hear, if he's had a heart
OP.
attack in the past, that should cue you in. Oh, did they give you any medicine to take if that happens again? He'd have been like, yeah, I got these little pills right here. How many of those you take? 2. Okay, well, that's probably a good reason why our blood pressure is shit.
But also, God, when you walk into the room, remember, it's a mannequin. We have to ask, what do they look like? Like, what am I looking at? Like, skin, color, condition, temperature. Like, ask those questions. While I'm checking a pulse, I'm standing beside them. Like, it has to become so robotic for you that you can't miss it, okay? It literally has to be the exact same thing with every single patient, to where I walk in, I'm grabbing the pulse of the patient. That's when I am looking, and I'm at that time would be when I would assess. But I'm going to look at here. I'm going to look at Lisa and say, hey, what's my skin, color, condition, temperature right now on this patient, right? You don't even have to say right now. You just say, hey, I'm checking a pulse. What's my skin, color, condition, temperature right now? She gives me that information. Perfect. I'm going to put them on the monitor. What does my monitor show? And that's when they're going to hand you the monitor. I'm going to look at it. We'll do a quick run through. Hey, there's my heart rate. There's my blood pressure. There's my oxygen saturation. O2 sats low. We'll go ahead and pop them on some, depending on what it is. 92, nasal cannula. 84, non-rebreathing, right? It's going to guide me what I do when I'm looking at it. When I get that on there, then I'm moving on to the next thing. All right, I'm going to work through my questions. Signs and symptoms. What are all my signs and symptoms? Allergies, medications, last oral intake, events leading up to, right? Then my secondary assessment or maybe even primary in here. I'm going to OPQRST it. They're like, hey, what's going on with you? Chest pain. Boom. Chest pain leads me through OPQRST, right? Not behavioral emergencies or anything like that. It's going to lead me into this section of questions. And now I'm going to work through those questions before I move on to anything else. And I may even, before I'm like, hey, while I'm checking the pulse, checking skin, color, condition, temperature, I'm doing a head-to-toe rapid assessment. Do I see anything that stands out to me? Right? And if she says nope, then I've done that. Now I can move on, right? I'm checking boxes as I'm moving through. And so that I'm not missing something when I get through.
Did you ask what he was doing when it first started? I might have missed it if you said it.
I think all I asked about was the scene, was able to safely get to him,
Right.
and
Like
things
during
like
your
that. But I didn't ask what he was doing.
Okay. Like you said, it needs to be the same questions every time. I know it's repetitive and I know it gets bored and you're like, well, I don't want to do it that way every time. It's just like anything. It's a pilot with a checklist. They do it the same way every time. That way it's not forgotten, right? Same thing with patients. Okay? Anybody want to go next?
Hell yeah.
I like that enthusiasm, sir.
Make up for my last one. Did you do team lead on your last one?